Extrinsic allergic alveolitis. Etiology. Extrinsic allergic alveolitis, EAA, also known as hypersensitivity pneumonia, is caused by hypersensitivity to inhaled organic dusts. The best known type is farmer's lung, but an enormous range of agents has been reported to cause the condition. Table 31. Epidemiology. EAA accounts for 2% of all occupational lung disease. Half of these cases occur in farmers. Pathology. Histological material is rarely available, but the condition begins as a nonspecific diffuse pneumonia that later develops the characteristic feature of epithelioid noncaseating granulomas. Fibrosis and obstruction or obliteration of bronchioles arises in parallel with inflammatory changes. Honeycombing occurs in advanced cases. Acute form of EAA. Clinical presentation. This can occur weeks to years after a sensitizing period of exposure. The patient develops recurrent flu-like illness, malaise, fever, headache, and general aches and pains, with a cough and breathlessness, usually starting about 6 hours after exposure to the relevant organic dust. Wheeze can occur but is not a typical feature. Breathing difficulty can range from trivial to life-threatening. Physical signs. Fever. Respiratory distress. Basal crackles. Clubbing is rare. Investigations. Unless the patient has recently been exposed to the precipitant, pulmonary function tests are likely to be normal. The CXR may be normal, but it characteristically reveals diffuse interstitial shadowing. This is particularly the case in lower and mid zones, resolving within 24 to 48 hours after exposure has ceased. The history is often diagnostic, but it may be necessary, particularly in circumstances not known to be associated with EAA, to make industrial hygiene measurements, e.g. with personal samplers, so that respirable agents can be identified. The demonstration of a serum IgG antibody response to the inducing organic dust is the most widely used method of confirming hypersensitivity. A negative test effectively excludes EAA to that antigen, but false positives are common. When the diagnosis is in doubt, inhalational challenge tests are sometimes used in specialist centers. Differential diagnosis. A single episode must be distinguished from other acute parenchymal lung disorders associated with systemic symptoms, the most common of these being infection. Distinction of recurrent episodes from organic dust toxic syndrome, usually caused by fungal toxins, and nitrogen dioxide pneumonia, Psilophyllers disease, can be extremely difficult in those at risk of all these conditions. Treatment. In an acute episode, spontaneous recovery begins within 12 to 24 hours of removing the sensitizing antigen. Steroids can hasten improvement, but there is a concern that they may increase the risk of recurrence. Respiratory support, oxygen and, rarely, mechanical ventilation, may be needed in severe cases. Prevention. Avoidance of exposure is the counsel of perfection, but is easier said than done in many cases. Patients may be unwilling to put their livelihood, e.g. farming, or hobbies, e.g. pigeons, at risk. Exposure can be reduced by changing work practices or the use of industrial respirators. If monitoring suggests that disease is progressive despite these maneuvers, then exposure must cease. An affected worker may be entitled to compensation. Prognosis. Continuing exposure and repeated acute exacerbations can lead to permanent impairment of lung function, but this is relatively uncommon. Occupational aspects. The environment that has caused illness in one individual may pose a risk to others. It may be necessary to survey the exposed population at risk, e.g. with questionnaires about respiratory symptoms and serological tests. Chronic form of EAA. Clinical presentation. This presents as a gradual reduction in exercise tolerance because of worsening breathlessness. There is no systemic upset, except sometimes weight loss, and no acute exacerbations. It most often occurs in those exposed continuously to a low level of antigen, e.g. a patient who keeps a single budgerigar, parakeet, at home, rather than someone exposed intermittently to high levels of antigen. Physical signs. Respiratory distress. Widespread crackles, as in other forms of diffuse parenchymal lung disease, but in contrast clubbing is uncommon. Signs of pulmonary hypertension and right heart failure may develop. Investigations. Pulmonary function tests reveal restricted ventilation, forced vital capacity diminished in proportion to forced expiratory volume in 1 second, increased residual volume and impaired carbon monoxide transfer factor. The CXR can show a range of patterns, including diffuse interstitial shadowing, honeycombing and fibrotic changes, in the upper lobes particularly. High-resolution CT scanning is more sensitive than the CXR, again showing a range of appearances, with a mosaic pattern being most characteristic. Bronchoscopy and bronchoalveolar lavage is useful in excluding other diagnoses, and a lung biopsy may be needed to distinguish from other causes of diffuse parenchymal lung disease in some cases. Differential diagnosis. The main differential diagnosis in many cases is sarcoidosis, as well as other granulomatous lung conditions. Treatment and prevention. Avoidance of exposure, as indicated above for acute EAA. Steroids are again thought to hasten improvement, but the optimum dose and duration of treatment is not known and, as for acute EAA, their use may be associated with relapse. Complications and prognosis. Many patients continue their antigenic exposure despite medical advice to the contrary. Some cases develop respiratory failure, but this is relatively uncommon. Occupational aspects. As for acute EAA,